Magandang araw po sa inyong lahat and welcome once again to our pre-recorded video lecture for the subject Nursing Care of the High-Risk Newborn to Maturity. I'm Dr. Jeffrey Reboron, and as you can see right now, I'm in a different setting because as of the moment, I am on my 16-hour duty inside the delivery room. And it's just very fitting for our lesson for this day because I am in an environment where usually these conditions happen. So please bring out your handouts and your ball pens because we will have a fun-filled day learning the different problems or acute conditions of the neonate. As mentioned earlier, during this series, we will be looking into the different acute conditions of the neonate. But for this video, we will be focusing our attention on respiratory distress syndrome. However, we will also be tackling meconium aspiration syndrome, blood incompatibility, sudden infant death syndrome, sepsis or infection, and we will also be looking into neonate of a diabetic mother and neonate with fetal alcohol syndrome. So we have so many conditions to learn, so you have to bring out your handouts and take notes because some of the trinkets of knowledge will not be coming from your handouts but will still be coming from me. So listen intently for this one. Now, as mentioned earlier, we will be zeroing in or focusing on respiratory distress syndrome or RDS. Now, you have to remember that this disease condition has been termed formerly as the hyaline membrane disease. But because of advancements in science and technology, it is already termed as respiratory distress syndrome. Now, kanino nag-o-occur yung ating RDS or yung hyaline membrane disease? Typically, this condition of the neonate usually is seen in preterm infants, although we also see this in infants who are born of diabetic mothers or mothers with diabetes mellitus. Also, we see RDS in patients who are born in cesarean section delivery and in other patients who have conditions that lead to poor lung perfusion or blood perfusion in the lungs. So those are the people who are mainly affected by respiratory distress syndrome or RDS or the hyaline membrane disease. Now, paano ba nangyayari ang ating RDS or respiratory distress syndrome? Let's look into its etiology. Now, you have to remember that in RDS, there is a fibrous membrane or a hyaline-like membrane formation in the alveoli. And these are usually from the exudates that come from the infant's blood. Ang nangyayari is that this fibrous membrane lines the bronchioles, the alveolar duct, and the alveoli. So, ibig sabihin may parang namumuong kulapot or membranous or fibrous membrane doon sa mga nabanggit natin na bronchioles, alveolar ducts, and alveoli. And because of the presence of this membrane, they prevent oxygen and carbon dioxide exchange. And ang nangyayari is because of the presence of that membrane, there is also poor lung perfusion. Kasi nga hindi na po nakakadaan ng maigi yung ating oxygen and carbon dioxide because of the presence of the hyaline-like membrane in the bronchioles, the alveolar ducts, and the alveoli. Another reason why there is RDS is that there is a lack of surfactant or what we call the lecithin and sphingomyelin. Ano ba kasing nangyayari when we have surfactants? As mentioned in our previous meeting, these surfactants line the alveoli and prevent surface tension to prevent atelectasis. Ibig sabihin, pinipigilan nito ang pag-collapse ng ating mga alveoli during exhalation or expiration. So, isa din ito sa ating mga reasons why there is respiratory distress syndrome because of the lack of surfactants. Now, dahil nga sa meron tayong poor oxygen exchange in the alveoli because of the presence of this hyaline-like membrane or dahil nga sa nakulang tayo sa surfactants, what will happen is that there will be poor oxygen exchange which will now lead to hypoxia or low level of oxygen in the blood. Now, this will cause the body to shift from aerobic respiration or aerobic metabolism to anaerobic metabolism. So, alam na natin ito noon because it has already been previously discussed, at ang mangyayari if there is anaerobic metabolism is that it will lead to the release of lactic acid, thereby causing metabolic acidosis. So wag na kayong magtaka kung yung mga pasyente natin na merong respiratory distress syndrome ay nagkakaroon sila ng acidosis kasi nga it is from the lack of oxygen exchange which leads to hypoxia. Again, nag-shift kasi yung ating katawan sa kanyang metabolism kung mababa yung ating oxygen level, and it shifts from aerobic metabolism to anaerobic metabolism. Therefore, dumadami yung lactic acid natin sa katawan. At ano ba kasi ang nangyayari pag meron tayong acidosis or masyado tayong maraming lactic acid in the body? Well, it aggravates the situation because acidosis tend to lead to further vasoconstriction and decreased pulmonary perfusion. So, anong mangyayari? It will make the condition even worse. Kasi nga, the reason why we have that hyaline-like membrane formation is that konti lang yung dugo na pumupunta sa ating lungs. Pero, pag merong acidosis, mas nagiging constricted pa yung mga blood vessels that are going to the lungs. Therefore, mas mababa pa yung oxygen na pumupunta sa ating mga lungs, thereby worsening the situation. So with the lack of oxygen going to the lungs because of vasoconstriction, ang mangyayari is that it will also limit the production of surfactant. So as you can see, no, nagpa-pile up yung problema because of the presence of acidosis. Merong vasoconstriction preventing the lung perfusion, and meron din siyang vasoconstriction that also inhibits or prevents surfactant production. So, anong mangyayari kung kukunti din yung surfactant na maproproduce? This will again lead to alveoli collapse or what we call atelectasis. Now, how do we assess for respiratory distress syndrome? Actually, there are subtle signs and symptoms that are seen after resuscitation. Now, subtle lang yung mga signs na nakikita natin after resuscitation kasi nga, during resuscitation, there is initial release of surfactants. Now, ano yung mga subtle signs na ito ng RDS na usually nakikita natin after resuscitation? Number 1 is low body temperature. Okay? Number 2 is that there is sternal or subcostal retractions. As you can see in the picture, dito po yung bata, pag nakikita niyo dito sa kanyang sternum, medyo indented po siya paloob. Indented siya paloob, so that's what we call sternal retraction. Meron din tayong nakikita dito in between the ribs, which we call subcostal retractions. Nakikita po natin yan as the subtle signs and symptoms of RDS. Always remember, class, na pag nakita ninyo yung word na retraction, it always is a danger sign for our patients, especially for pediatric patients, because it means there is difficulty of breathing or labored breathing. Iso nga masuluy na pay dagijayanti subcostal ken sternal nga areas nan because of too much exertion of effort. Kasi nga po nahihirapan siyang huminga. Therefore, nakakakita tayo ng retraction. Another subtle sign that we see in patients with RDS is there is nasal flaring. In Ilocano, agbusingar deja agungda nga aganges. So it also is a sign of labored breathing or difficulty of breathing. So ngano makita yu deja ubing nga agang-anges, agbusingar deja agung na, or nasal flaring, that means that there is possible respiratory distress syndrome. Aside from that, there is also an increase in the respiratory rate or what we call tachypnea. So how can we consider if a patient is tachypnic? If there is more than 60 cycles per minute na respiratory rate. So those are the subtle signs of respiratory distress syndrome that we see after resuscitation, upon the initial release of surfactants. Now, after those subtle signs, after resuscitation, usually within several hours after resuscitation, makakakita tayo ulit ng respiratory grunting. I will be playing a clip after this slide so that you will know better or hear better what respiratory grunting is. So, in our patients with RDS, makakarinig po tayo ng respiratory grunting, okay, which I will be playing the audio now.
Infant distress means your baby is having difficulties. Knowing what to look for will help you know if your baby is in distress. Your baby may have breathing problems, such as retractions, grunting, and apnea. Retractions are unusual breathing movements. With each breath, your baby's chest muscles pull in the skin around the bones. Grunting is a noisy breathing sound. Your baby may grunt to keep air in the lungs. Grunting may sound like snoring or singing. Apnea is a condition in which your baby pauses breathing for 15 to 20 seconds. Then continues breathing. You may notice changes in your baby's skin. Two common findings are conditions known as cyanosis and jaundice. Cyanosis is a blue skin color. You can usually see it around your baby's lips, chest, and stomach. This blue color means that the oxygen level in the blood may be too low. Cyanosis may mean there is a problem with the baby's lungs or heart. Jaundice is an overall yellow skin color. It happens when a substance called bilirubin builds up in the blood. Most babies have some jaundice that appears more than 24 hours after birth. If left untreated, severe or long-lasting jaundice may cause brain damage. It's important to check your baby for these signs of distress. Immediately contact a member of your healthcare team if you notice any of these warning signs.
So that's how respiratory grunting sounds like. Aside from respiratory grunting, makikitaan din natin yung ating pasyente ng cyanosis after a few hours ng resuscitation. Pag meron siyang RDS, makikita natin that there is bluish discoloration on the skin of the patient. So that is typical for patients with respiratory distress syndrome. Aside from that, makakarinig din tayo ng fine rales. This is again another lung sound which I will be playing right now so that you will be familiar of how fine rales sound. Aside from that, there will also be diminished breath sounds because of poor air entry. Kasi nga po, merong hyaline-like formation na nabumabalot sa ating alveoli and bronchioles, kaya po, konti lang yung oxygen exchange na nangyayari. Therefore, there will also be diminished breath sounds because of poor air entry. Lastly, makikitaan din natin yung mga pasyente natin with respiratory distress syndrome ng seesaw respiration. Sa seesaw respiration po, usually, yung inyong abdomen and yung kanyang chest nagsisiso po yan. Kaya siya tinawag na siso respiration. Bakit? Because during inspiration or inhalation, the sternum retracts and then the abdomen will protrude. And during expiration, the sternum will arise and the abdomen will sink. As you can see in the picture. Normally po, pag titignan natin yung normal respiration ng bata, if there is inspiration, magkakaroon po ng rise in the sternum and rise in the abdomen. Pareho po silang aangat pag kayo ay mag-i-inhale. But in siso respiration, during inspiration or inhalation, the sternum retracts while the abdomen protrudes, and then pag nag-exhale yung bata, yun namang sternum niya mag-arise and then the abdomen will sink. So the chest wall retracts while the abdomen rises with inspiration. So yan po yung nangyayari sa ating siso respiration that is typically seen in respiratory distress conditions. Again, I will be playing to you finals and respiratory grunting para po mas madali nating maintindihan. Now, aside from those mentioned a while ago, makikita din natin yung bradycardia in our patients, wherein their heart rate will start to fall. So, yung kanilang mga heart rate magiging less than 80 beats per minute, typically seen in patients with RDS. And there will also be oliguria or diminished urination. So, makikitaan din natin na konti lang or halos hindi na din umiihi yung ating mga pasyente. Why? Because there is also low perfusion in the kidneys, therefore, konti lang po yung kanyang urine output. Aside from that, there may also be edema on the extremities. Pag nakita po natin na namamanas na yung kanyang mga extremities, that may also mean that there is already a beginning heart failure. And sometimes their color becomes gray. Nagiging pale gray na po yung patient until sa nagkakaroon na siya ng periods of apnea or absence of respiration. So those are also signs and symptoms of patients with respiratory distress syndrome within several hours after nating mag-resuscitate. Now, ang question natin for sure is how do we determine if the condition of the patient is respiratory distress syndrome? Now, meron tayong mga clinical signs na pwedeng tignan so that we can consider if that patient is really suffering from respiratory distress syndrome. Number 1 dyan ay yung grunting sound na nahihear natin on both lung fields. Again, I will be playing what grunting sound is for you to be more familiarized of it. There is also cyanosis in room air. Di ba nga po yung mga ibang pasyente natin na mga pedia patients, they only get cyanotic if there is cold environment or cold temperature. Pero in patients with respiratory distress syndrome, nagkakaroon sila ng cyanosis even in room air or in room temperature lang. So that is also one clinical diagnosis or clinical sign that you should consider in respiratory distress syndrome. Aside from that, there is also tachypnea or fast respiration or respirations that are more than 60 cycles per minute. There is also nasal flaring or agbukirad deja agungda when they inhale. That means that there is labored breathing or difficulty of respiration. There are also signs and symptoms of shock, including tachypnea, tachycardia. There is also hypotension and hypothermia. Those are the signs and symptoms of shock, along with cold, clammy skin. Another thing that we can do is the doctor may order that the patient be subjected to chest x-ray. Ano yung titignan natin dito? We will look into the haziness of the lungs. So, nakikita natin dito sa picture dito sa normal lung fields that the lungs are colored dark or blackish in appearance. That's the normal appearance of the lungs in your chest x-ray. However, if a patient has respiratory distress syndrome, the lungs may appear light in appearance, as you can see on the next picture here. Aside from that, you can also subject the patient in blood gas studies. Okay? Gusto nating tignan yung ating level of acidity or alkalinity in the blood of the patient. So usually, nakakakita tayo ng respiratory acidosis or metabolic acidosis in these kinds of patients with respiratory distress syndrome. So those are the clinical signs of RDS. Now, after nating ma-diagnose or makita that our patient has respiratory distress syndrome, what do we do? The number one thing that we can do is to do surfactant rescue or surfactant therapy. So the newborn is placed in endotracheal tube for spray administration of the surfactants at birth or at the time wherein the symptoms will appear. So as you can see here, the patient is placed or given an endotracheal tube because that will be used as our route for the insertion or administration of the surfactant. Now, the best position when you are giving the endotracheal tube for surfactant rescue is that the head of the neonate should be held upright. Okay? Because in that way, it facilitates the entry of the drug and also facilitates the entry of the tube for that so that the doctor can better visualize their entry point. Then, after that, after insertion of the endotracheal tube and after administration of the surfactants, the head should be tilted down again to ensure the opening of the airway. Aside from that, you have to remember that when you have given surfactant to the patient, it is best that you do not suction. Okay? Hindi po tayo magsa-suction right after giving the surfactant because we might suction away the drug. Always remember that the surfactants were given as a spray administration in the endotracheal tube, and suctioning the patient right after that may just remove the surfactants from the tube. So, hindi lang din makukuha ng pasyente yung kailangan niyang surfactants pag sinuction mo siya agad. Aside from that, you can also put the patient in mechanical ventilator. Okay? Bigyan natin ng mechanical ventilator si pasyente to facilitate lung expansion while waiting for the drug effects or the surfactants to take effect. Okay? So you have to remember that when you place the patients in mechanical ventilator, we always make sure that we monitor the pressure of the oxygen to prevent retrolental fibroplasia or neonatal blindness. So that's number one thing that we can do for patients with respiratory distress syndrome, to give surfactant rescue or surfactant therapy. Aside from giving surfactant therapy, we can also give oxygen administration to our patients. Bakit tayo magbibigay ng oxygen? Kasi nga po merong hypoxia in respiratory distress syndrome. And when we say hypoxia, it means low level of oxygen. Now, oxygen administration is typically given to maintain the pH or the acidity of the blood and prevent acidosis. Kasi nga po, gusto natin that the body will have sufficient oxygen so that it will not shift its metabolism from aerobic to anaerobic para po hindi mag-release ng maraming acids, lactic acids that will lead to acidosis. Kaya magbibigay dapat tayo ng oxygen to prevent acidosis from happening. So again, we can hook the infant in mechanical ventilator, and as much as possible, make sure that we use CPAP or PEEP. And when we say CPAP, it means continuous positive airway pressure. Pag sinabi po nating CPAP, yung setting ng ating mechanical ventilator, the CPAP is used to deliver constant and steady air pressure to help the patient breathe. Okay, so that's what we call CPAP. Kaya siya tinawag na continuous positive airway pressure because it delivers constant and steady air pressure to assist the patient in their breathing. However, they can also use PEEP, or the positive end expiratory pressure. Now, at the end of the mechanical or spontaneous exhalation, di ba no, agangis tayo? Now, the PEEP maintains the patient's airway pressure above the atmospheric level by exerting pressure that opposes the passive emptying of the lung. Ibig sabihin, during expiration kasi or exhalation, doon sumasabog yung ating mga alveoli pag merong RDS or respiratory distress syndrome. Pero, ang mangyayari because of the PEEP, halos pagpatapos na yung exhalation, doon papasok yung positive pressure. Kaya siya tinawag na positive end expiratory pressure to prevent the alveoli from collapsing upon expiration. Again, like I said a while ago, when you hook the patient in mechanical ventilator, you have to monitor oxygen administration and prevent retrolental fibroplasia. So yun po yung lagi nyong tatandaan for our patients who are hooked in oxygen or mechanical ventilators. Now, aside from giving surfactant rescue and hooking the patient in mechanical ventilator, another thing that we can do when we are therapeutically managing patients with respiratory distress syndrome is the administration of indomethacin. Bakit tayo kailangang magbigay ng indomethacin? The drug facilitates the closure of the patent ductus arteriosus. Kasi alam natin that both RDS and the patent ductus arteriosus are comorbidities. Now, sinabi natin kanina that patent ductus arteriosus or PDA are common comorbidities in very premature infants. So, typically, nakikita natin, like I said a while ago, nakikita natin yung RDS sa mga preterm infants, and along with RDS, baka meron din silang patent ductus arteriosus. That's the reason why we have to consider na baka yung patient natin ay meron ding PDA, kaya tayo kailangang magbigay ng indomethacin pag nakikitaan sila ng signs of respiratory distress syndrome. Now, premature infants with PDA may develop respiratory distress syndrome, kaya kailangan din nating magbigay ng indomethacin to facilitate the closure of the ductus arteriosus. And the indomethacin should be given or administered intravenously by syringe for at least 30 minutes. So yun po ang ibibigay natin to help in the closure of the ductus arteriosus, ang drug na tinatawag natin na indomethacin, because PDA is usually a comorbidity of the respiratory distress syndrome. So you have to also consider that route. But then again, it's always up to the doctor's order if there is a need to inject or give indomethacin to our patients with RDS. We also have to remember that another therapeutic management for respiratory distress syndrome is what we call thermoregulation. So, na-discuss na natin ito before, that when a patient is not thermoregulated, giniginaw sila, they will spend more energy creating heat, and therefore, it will aggravate the situation. So, anong dapat natin gawin? We place the infant in radiant warmer to prevent cooling and to prevent acidosis that may aggravate the problem. And we also keep the infant warm, and so as not to increase the need for more oxygen and energy expenditure because of chilling. Aside from that, when we place the patient in infant warmer, we also have to consider hydrating the baby with either intravenous fluid as per doctor's order, of course, and also we can consider giving them breast milk or formula milk or gavage feeding if the child with RDS is unable to suck. So those are the things that you can do in managing thermoregulation for patients with RDS, And lastly, we also have to tackle how we can prevent respiratory distress syndrome. Now, you have to remember that your RDS usually happens in patients who are preterm. And respiratory distress syndrome rarely occurs in mature infants. So anong gagawin natin? We have to consider doing diagnostic procedures for our patients who may have preterm delivery. So ano yung pwede nating i-suggest sa ating mga patients as per doctor's order? We can suggest that the patient have amniocentesis, or properly i-date natin yung kanilang mga pregnancy or age of gestation via ultrasound so that we can properly assess if the patient is term or preterm. Kasi nga po, ang RDS nakikita natin for patients who are preterm, I should say. So again, kailangan natin gawin yung amniocentesis or the aspiration of amniotic fluid, and then sonogram or ultrasound for us to better assess the age of gestation para malaman natin kung enough na din ba yung lecithin and sphingomyelin ratio. You have to remember that dating the pregnancy para malaman natin kung more than 7 months na siya is important because surfactants are only formed during the 7th month of life. So, kailangan natin gawin yung amniocentesis para malaman natin kung meron na siyang lecithin and sphingomyelin, at kailangan din natin gawin yung sonogram for us to determine the age of gestation in case wherein the patient does not know her LMP. Aside from that, kung yung pasyente natin still nagkakaroon siya ng preterm contractions, 6 months or 7 months pa lang yung pasyente natin na buntis ay nagkakaroon na siya ng contractions at hindi na mapipigilan, we can give or administer tocolytics. Okay? Usually kasi yung mga preterm contractions, pwedeng ginagawa lang yan is complete bed rest. At pag nag-complete bed rest kasi yung pasyente, mawawala po yung premature contractions. But in the event na hindi na po kayang labanan ng complete bed rest yung preterm contractions ng pasyente, the best that we can do is we let the patient go to the doctor for her to be given tocolytics. At ano ba kasi yung mga tocolytics natin? These are drugs that are anti-contraction and they are labor suppressant. Ibig sabihin, pinipigilan nila ang pag-contract ng uterus, therefore preventing delivery. Now, these tocolytics are medications that are used to suppress premature labor. So, binibigay lang po natin ito sa mga pasyente na may premature contractions. And what are the examples of your tocolytics? You have your magnesium sulfate or your Magsul. We also have your indomethacin, and we also have nifedipine. All of these drugs are considered tocolytics that may prevent preterm delivery by helping the uterus to relax para mag-stop po na mag-muscle contraction yung uterus ng pasyente para ma-delay natin yung delivery at hindi mag-progress into preterm delivery yung contraction ng pasyente. Now, in the event na nagbigay na po tayo ng tocolytics, pero yung pasyente panay-panay pa din ang kanyang pag-contract at hindi na talaga mapipigilan yung kanyang pag-deliver preterm sa kanyang anak, the best bet that we can do is we give steroids to the mother. Bakit tayo magbibigay ng steroid in the event na baka mag-preterm delivery na yung pasyente natin? 2 shots of the steroid called betamethasone to the mother within the 12 to 24 hours before delivery will hasten the formation of surfactants. So, ibig sabihin, pag hindi na talaga mapipigilan yung paglabas ng preterm na bata na ito, the best that we can do is ensure that that child who is going out of the womb of the mother preterm, okay, or before its term, ang gusto natin ay masigurado na meron na siyang enough surfactant. And how do we hasten? Paano natin mapabilis yung production ng surfactant na ito? By injecting to the mother 2 shots of betamethasone 12 to 24 hours before her delivery, which will hasten the production of surfactants. Tatandaan nyo lagi na your surfactants, your betamethasone, I should say, will only take effect in 24 to 48 hours. So, very important po na binibigay na natin ito 12 to 24 hours before the delivery so that we can hasten the production of surfactants. Now that ends our discussion along the topic respiratory distress syndrome. And in as much as I would like to lengthen our discussion for today, like I said, I'm still on duty, therefore I cannot spend most of my time lecturing you online if baka meron dumating na pasyente dito bigla-bigla. So again, I should end our online class right here, right now. So that will be the end of our discussion for today. You have to review for our midterm examinations, which will happen in a few short weeks or days. So again, maraming salamat for still attending my classes. Have a great day everyone. Enjoy the rest of the day and keep safe. Maraming salamat sa inyo.